Pneumonia, a clinical overview. Welcome to our medical tutorial series on pneumonia. This is the first video in our comprehensive series where we break down all essential aspects of pneumonia, from its types, pathophysiology, clinical presentation, diagnosis, and treatment strategies for different patient groups. Whether you are a medical student, a resident, or practicing clinician, this series is designed to give you the clinical knowledge you need for everyday practice. Make sure to watch till the end and don't forget to like, share and subscribe to our channel. 10 daily medical questions for more such educational content. Let's get started. Definition: Pneumonia is an acute infection affecting the lung parenchyma. It typically results in inflammation of the alveoli, causing them to fill with pus or fluid, leading to impaired gas exchange. Clinically, this presents as cough, fever, dyspnea, and sometimes pleuritic chest pain. Let's now dive into the types of pneumonia. Types of pneumonia. Pneumonia is characterized based on where and how the patient acquired the infection. Community-acquired pneumonia (CAP) occurs outside of hospitals or healthcare facilities. Hospital-acquired pneumonia (HAP) develops 48 hours or more after hospital admission. Ventilator-Associated pneumonia (VAP) is a subset of hospital-acquired pneumonia occurring after endotracheal intubation. Aspiration pneumonia results from inhalation of oropharyngeal secretions. Lastly, atypical pneumonia refers to infections by pathogens like Mycoplasma pneumoniae, Chlamydophila pneumoniae, or Legionella pneumophila, often presenting with less severe respiratory symptoms but more systematic involvement. Pathophysiology and pathology of pneumonia. Pneumonia can develop through various mechanisms: inhalations of airborne pathogens, microaspiration of oropharyngeal secretions, hematogenous spread from distant sites of infection, or direct extension from nearby infected structures like pleural space infections. This leads to an inflammatory cascade, damaging the alveolar capillary membrane and filling the alveolar space with exudates. Clinical presentation and differential diagnosis. Let's talk about the clinical presentation of pneumonia, an essential part of recognizing and diagnosing this condition. Typical symptoms include cough, which may be productive or dry, fever and chills, dyspnea, shortness of breath, pleuritic chest pain, sharp pain that worsens with breathing or coughing, fatigue and malaise. In elderly patients, altered mental status can sometimes be the only presenting symptoms. Differential diagnosis. Now, let's move to the differential diagnosis, crucial to rule out other conditions that may mimic pneumonia. Pulmonary embolism presents with sudden onset dyspnea and pleuritic pain but often lacks fever. Heart failure causes pulmonary congestion and dyspnea, but usually with bilateral crackles and no fever. Tuberculosis, chronic symptoms like weight loss, night sweats, and hemoptysis. Lung cancer, often associated with a persistent cough and hemoptysis. Acute bronchitis, presence with cough and sometimes fever, but without significant lung consolidation on imaging. Differentiating these conditions require a combination of clinical judgment, imaging, and lab tests. Diagnosis and decision making. Once a patient suggests with suggestive symptoms, the next step is diagnosis, starting with a detailed clinical history and physical examination. Chest X-ray are key in confirming pneumonia, showing areas of consolidation. CT scan may be considered for complicated cases. Blood and sputum cultures, along with PCR tests, help identify the causative pathogens, especially crucial in severe or hospitalized cases. Decision to hospitalize. A crucial part of pneumonia management is determining whether a patient requires hospitalization or can be treated as an outpatient. One of the most widely used tools for this is the CURB 65 score. Let's break it down. C for confusion. New disorientation to person, place, or time. U for urea, a level greater than 7 millimole per liter. R for respiratory rate, 30 breaths per minute or more. B for blood pressure, systolic less than 90 mm of mercury or diastolic less than or equal to 60 mm of mercury. Age 65 or older. Scoring 0 to 1 points, outpatient treatment is appropriate. 2 points, hospitalization should be considered. 3 or more points, assessed for ICU admission. This score helps guide clinical decisions by stratifying patients based on the severity of their pneumonia. Treatment and antibiotics. Let's now break down the treatment strategies for pneumonia, focusing on antibiotic choice for different settings. CAP outpatient. For otherwise healthy patients with mild CAP, the first-line therapy is amoxicillin, 1 gram 3 times daily, or doxycycline, 100 mg, twice daily for 5 days. CAP inpatient non-ICU. For patients requiring hospitalization but not ICU care, combination therapy with ceftriaxone plus azithromycin IV is recommended. HAP empiric coverage often includes piperacillin tazobactam or meropenem to target gram-negative and resistant organisms. Aspiration pneumonia. If aerobes are suspected, clindamycin or amoxicillin clavulanate is appropriate. It is crucial to tailor therapy based on local antibiograms, patient's risk factors, and specific pathogen identification whenever possible. Thank you for watching this comprehensive overview of pneumonia. In our next video, we'll take a deeper dive into the pharmacological details of pneumonia therapy, discussing medications, dosages, indications, and contraindications in detail. Don't forget to like, share, and subscribe to 10 Daily Medical Questions for more medical insights and tutorials. Let's know in the comments if there's a particular topic you want us to cover. See you in the next video.